Hello, my name is William Rigby, and I'm here to talk to you about the advances in basic science at the ACR 2011 Annual Meeting. There were many fabulous advances, and I wish I could talk about all of them to you, but again, I only have 15 minutes, so I'm going to provide you with my favorites, and I hope that you enjoy them as well. I think there are some very interesting areas, and I'll summarize a couple of areas for brevity's purpose, but I direct you to look up these papers as I go over them. My talk is going to be first focused on novel insights about rheumatoid arthritis pathogenesis. We know that rheumatoid arthritis, in terms of anti-citrulated protein antibodies, ACPA, occurs years before the onset of joint symptoms. One of the questions is always if the tolerance is broken and signs and symptoms of signs of inflammation are detectable in the blood years before symptoms. Where is the disease? And to date, in preliminary studies, no joint inflammation has been demonstrable by imaging or synovial biopsy. Now, where is the locus of the disease if it's not in the joint? Is it in the lung, the gut, the gums? What I'm going to do is review a few studies, and in particular, a particularly exciting study on the lung association for rheumatoid arthritis. But let me first introduce you to North American natives in Canada of the Cree Ojibwe tribe and the first-degree relative population. There's a high frequency of RA there. The shared epitope is also present at a high frequency, and there's a lot of smoking. And what this group did is looked at the first-degree relatives of the patients with rheumatoid arthritis, trying to look at whether this is sort of a field disease or a breeding disease that exists in some preclinical form out in the community of these relatives. And they took North American native RA patients, 105, FDR, first-degree relatives of these patients, 273, healthy North American natives who were the NC or normal control, and Caucasian controls. Now, the healthy NAN are not healthy. They just have, for other reasons, they just have no family history of autoimmune disease, as do the Caucasian controls. Rheumatoid factor was positive in 88% of the RA patients in this Cree Ojibwe trial. The first-degree relatives, 34%, very high. Normal controls, 9%. North American controls, I should say, 9%, and Caucasian controls, 5%. They collected sera on these patients and also measured anti-CCP antibodies. It was 81% in the RA, 9% in the first-degree relatives, which is quite a high number, and 4% in the native controls and 0% in the Caucasian controls. Now, they looked at this serum and measured for signs of inflammation using a 42-plex cytokine and chemokine array. And what they found is of the samples that consistently gave them measurable values, 17 out of 40 were always higher in the FDR, first-degree relative population, relative to both the native controls or North American controls and the Caucasian controls. And you saw elevations in IL-1 beta, IL-6, TNF, MCP1, VEGF, and so forth. MCP1, macrophage chemoattractant protein, seemed to have the best predictive value. Now, for those of you who are thinking that, this first-degree relative is just a patient that's already preclinical and has broken tolerances and about to go on to develop rheumatoid arthritis, the fact of the matter, this was seen in the first-degree relative. These elevations were seen in the absence of rheumatoid factor in these relative populations. So it's almost as if the systemic inflammation began before they developed the break in tolerance. So in the summary of this, we are left with the pro- and anti-inflammatory cytokines, and by the way, the high sensitivity CRP were significantly held higher in patients who were in individuals that were first-degree relatives of North American native RA patients. Now, if you are North American native without a history of autoimmune disease, you have the shared epitope, you may smoke, but you don't seem to have these elevations in the cytokines and chemokines. Now, this is very suggestive of sort of a genetic susceptibility model over and above the shared epitope. And this reminds me of the story with HLA-B27, where HLA-B27 is associated with ankylosing spondylitis and seronegative spondyloarthropathies in some families, but not in others. So what it suggests to other genetic contributions and a broader genetic susceptibility model, other than the one suggested by the shared, in addition to the one suggested by the shared epitope. A fascinating observation. The next trial is equally fascinating, and this is also in the world of first-degree relatives. And this was done out of the University of Colorado as part of the SIRA group. And what they did is that they identified first-degree relatives who had positive autoantibodies, either ACPA and or Rheum2 rheumatoid factor, without any arthritis on a DAS68 joint exam, and they were imaged by chest CT. The seropositivity of having both ACPA and rheumatoid factor was present in 36 of the 45. 9 of the 45 had both IgM and IgA rheumatoid factor. And a third of them, 15, were smokers. Now, they compared these studies, these CT scans, on normal people without any chest symptoms, normal chest exam, normal joint exam. And they matched them with age, sex, and smoking matched controls, and was also compared to 12 individuals with CT scans with less than 1 year of RA. And they did a blinded CT reading by 2 observers. And the fascinating observation was that the antibody-positive cases exhibited airways disease, as shown below, bronchial wall thickening, bronchiectasis, air trapping, etc., in 77% of the cases. Now remember, these do not have rheumatoid arthritis; they have no synovitis. 31%. This was present in 31% of the controls. If you said, well, what if you got rid of the smokers and you just focused on the non-smokers in the control and in the antibody-positive population, antibody-positive with first-degree relatives, and the frequency of airway disease on CT in the 30 antibody-positive never smokers was 70%, so it's still quite high. It basically dropped a little bit, but the relative to the non-smokers or never smokers, it was 3 out of 12. The magnitude of the effect is still maintained. Now, for those of you who are thinking, well, they may have had subclinical rheumatoid arthritis with joint involvement, they did MRIs on 15 of their antibody cases that had an abnormal CT, and they saw absolutely no synovitis on the hand and wrist. Now, these airway changes were no different in these first-degree relatives who had no arthritis relative to the early RA population. In short, we have to conclude that airway disease occurs with the breaking of tolerance, or the breaking of tolerance occurs with airway disease. And this suggests that the lung might be a particularly good model for the development of rheumatoid arthritis, and that also that it does not necessarily require smoking to get lung involvement. Now, we'll have to wait further to see how these studies play out for other possible targets, but right now this moves lung disease right to the top of the list, and this is consistent with other studies suggesting the relationship of smoking to rheumatoid arthritis. So a fascinating observation, and one we'll just wait to play out. The third study that I wanted to touch base on was on this preclinical RA, which sort of adds on to the previous study. And this is where they looked at 49 patients who had rheumatoid factor and or ACPA positivity. And they did MRIs and synovial biopsies, and this is from the Netherlands. And they had 7 controls and 5 early RA. Now, of their 49 patients, so that they're imaging and biopsying, 1 year with a median of 1 year follow-up, 9 of the 49 developed RA. Moreover, 15 of the 49 had arthralgia. And of those 15 that had arthralgia, 5 developed RA at 1 year of a median of 1 year follow-up, or 33%. Now, what's fascinating is that although we know that 18% of the patients developed RA, in the total population of 5 out of 15 developed RA in the patients with arthralgia, relative controls, baseline MRI, and biopsy showed no difference. In other words, rheumatoid factor positivity, ACPA positivity, the presence of arthralgia, the presence of subsequent development of rheumatoid arthritis, no evidence in the joint. So these synovial biopsy studies and MRI studies are clearly different relative to early RA. And what I really want to emphasize is that the history of arthralgia did not influence their findings or change the data. So I think the interpretation about this from both this and the previous study is that it's not that rheumatoid arthritis smolders in the joints for a long period of time before it becomes clinically evident. At least that would be an explanation to be consistent with this data. Now, the second component program overview is the application of high-throughput sequencing techniques to understand human disease. There were a number of papers, and I just want to briefly summarize that these are areas that are embryonic and are about to yield fascinating insights. And these insights will be in these four basic domains. One, the ability of high-throughput sequencing to sequence all T-cell receptors and their usage in rheumatoid arthritis. And there's a fascinating group from the Netherlands, which is actually doing this not just in the joint, but doing this in the inguinal lymph nodes of patients with preclinical rheumatoid arthritis. Another group reported on data analyzing the entire transcriptome, that is all mRNAs that are being synthesized in the synovium prior to the treatment to predict clinical response. So this is, you biopsy the synovium, you sequence every gene that's being expressed, and then you see whether then after you treat with a particular drug, you see whether they respond better if they have a particular signature or a particular gene expressed. A fascinating set of work that I think may revolutionize how we think about the biology of rheumatoid arthritis, if not many other diseases, was presented by Bill Robinson, where he profiled the ability to examine the antibody response in a disease state as well as in a normal at a single cell level by sorting circulating plasmablasts from the peripheral blood and cloning out the heavy and light chains from a single B cell and identifying what they are and what they react with. Finally, I think many individuals are looking at the comparison of entire genome sequences in rheumatoid arthritis as well as other disease states to try to find unique immunodeficiencies or unique predictors of clinical response or unique insights into pathogenesis. Now, my final slide is in this basic science domain is to talk about a single paper presented on adoptive immunotherapy. And I'm not sure where this is going, but this is a fascinating area to think about, and I'll share with you the data. Now, adoptive immunotherapy in cancer follows the basic arrangement shown on this slide. You apheresis blood from patients. You grow up dendritic cells and expand them in vitro and let them mature into active antigen-presenting cells. You pulse them with tumor antigen, and then you put them back into the host. And shown on the left-hand side is a dendritic cell with increased levels of cell surface markers like CD40 and CD80 and 86, indicating that it's a mature, active dendritic cell. It's been pulsed with an antigen, so it expands T cells that are specific for that antigen. And because the dendritic cell, due to activation and expression of NF-kappa B and the expression of many high levels of these surface markers that are co-stimulatory molecules, provides signal 2, and then T cells expand, and the T cells expand and subsequently provide help that allow expansion of cytotoxic T cell generation and tumor killing. Now, the problem with this in rheumatology is that if you were to repeat this process, meaning apheresis the patient, expand dendritic cells in vitro, just a simple expansion of dendritic cells makes them activated. You would then pulse them with antigen, put them back into the host, and you would get an expansion of antigen-specific T cells, and you would get macrophage activation and inflammation. In other words, a disease flare. Or is it? So the adoptive therapy approach in rheumatoid arthritis would be you need to know how to tolerize. If you want to tolerize, you have to know the antigen, and you also need to have an immature dendritic cell to give the antigen to in vitro. Well, the Rheumavax approach by a group in Australia said, well, we know the antigen, it's citrullinated peptides, and what we want to do is we want to expand immature dendritic cells and keep them from maturing in vitro when we grow them up. And the answer is you can do that by keeping the dendritic cells in the when you're culturing them up in the presence of an NF-kappa B inhibitor. So this is shown on the next slide. You pherese the cells. You maintain them as immature dendritic cells by growing them in the presence of an NF-kappa B inhibitor. You pulse them with antigen. And please note now the dendritic cell has no NF-kappa B activity. It has no CD40 on its cell surface. It has no CD80 or 86 on its cell surface. Therefore, signal 2 that it gives, the co-stimulatory signals to the T cells are lessened, and instead of getting helper T cell expansion, you get increased numbers of T regulatory cells and a tolerogenic macrophage phenotype. In short, you get phenotype, you get tolerance. So the Rheumavax approach was to do this. They took immature dendritic cells, grew them up for 48 hours with IL-4, GM-CSF, and an NF-kappa B inhibitor. They pulsed them with citrullinated peptides, the vimentin, fibrinogen, and collagen, and then put them back into the patients as part of a phase 1 clinical trial. This is not an efficacy trial, and so they did not. This is a safety trial, so they did not require marked rheumatoid arthritis activity. And what they did is they gave this to patients who had the shared epitope positivity and had antibodies to citrullinated proteins, indicating that they had a citrullinated protein biased rheumatoid arthritis. The injection was done at time 0 with either 1 or 5 million dendritic cells given sub-Q. These are, remember, immature dendritic cells pulsed with citrullinated peptides. And they monitored their responses at 1, 3, and 6 months. And they were looking for safety as well as clinical response. Well, the safety first. They did 6 patients and there were no major signals. In terms of efficacy, the disease activity score declined in all at 1 month. CRPs declined, not the CRP, but the DAS declined in all months. The swollen joint count, tender joint count. There was 1 flare, and a patient was rapidly tapered off steroids. In the blood, they noticed there was a reduction in the byproducts to suggest indoleamine dioxygenase levels, which is a marker of greater T regulatory function, which is not what they expected. And the other thing that was interesting is that the patients who responded best were the patients whose C-reactive protein went up. That is, systemic inflammation, as manifested by maybe IL-6 production, was increased increased to predict the level of clinical response. In short, this was the opposite of what was predicted. So what we had is that they had these immature dendritic cells. They pulsed them with antigen, and there was no clear change in T regulatory cell function or macrogenic tolerogenic phenotype. Rather, what happened is that activation of macrophages and the production of IL-6, as evidenced by elevated levels of CRP, seemed to predict clinical response. This is confusing, but this is the data. So in terms of adoptive therapy in rheumatoid arthritis, the question is, can it be done? It appears it can be. Is it effective? It appears to be. How does it inform our disease understanding gained from the use of biologics? It's way too early to tell, but it may inform us in a totally different direction from the way we've thought about the use of biologics in the past. So I thank you very much for participating in this program today, and I wish you to look us up in many other opportunities and many other venues in the Rheumatology Highlights program report.